So we'll start out by saying the mission statement together. We, the Stonehill Franciscan Services Community, in the spirit of St. Francis of Assisi, offer a continuum of quality lifetime care services and dignifying atmosphere. So we wanted to talk about kind of a range of things today. We'll just kind of go through the PowerPoint presentation, and as you have questions, go ahead and ask, and we'll have different presenters today to kind of keep it more lively. Just a few housekeeping things. I know you all signed in this morning, so that's good. If you're not clocked in, please let me know that so that I can clock you in to make sure that we pay you for being here. Just a general reminder that Healthcare Academy Q3 assignments are due in 4 days. So if you need time to get those done, just let us know, and we can get you a work from home sheet if you're not able to do it when you're here. And then one of the things that we wanted to talk about, it came up at resident council. They had some concerns about cell phones at the nurses' stations. So just a reminder not to carry your personal cell phone when you're on the clock. Obviously you can use them on breaks, or if you have an emergency, just let us know and we will work with you on that. But yeah, just wanted to bring it up. Not sure if it pertains to anybody here or not, but they did bring it up at resident council, and it is something that we're going to keep an eye on. So one of the topics that we wanted to talk about today is readmissions. Starting October 1st, Medicare is going to automatically withhold 2% of our payment in a bucket. And then they're going to look at everyone's readmission rates to make sure that they're under 16%. So right off the top, Medicare is going to withhold 2% of all the money that they pay us. So we won't even see that 2%. And then at the end of the year, they'll look back and make sure that over the last year that our readmission rate was under 16%, then they'll pay us that 2%.
What
So,
if they come back for something completely different?
What's that? Oh, like for readmission?
Yeah.
It doesn't matter.
So like if they have a left hip done and they come back 6 months later
Oh, yeah, no, so there's a
with a
window.
right hip,
Yep, so there's a 90-day wellness period. That's a good
Okay.
question. So if someone does come in for post-acute care, they go home, they stay home for at least 90 days, that's a 90-day wellness period, and then they end up back in the hospital for something completely different, then that would not affect us.
that's what I was asking. All right.
Yep, good question. So a readmission is what Medicare would consider the number of readmissions that occur within 30 days of the resident's admission to us. And that could be for any reason. So if they come in for a left hip and we send them back over for a GI bleed, and it's totally unrelated to their diagnosis for admission here, that still counts against us. So it's kind of interesting, but that's why they do give you that margin of 16%, so that you can you have some wiggle room a little bit, but it's kind of a little hefty. So anyway, the other part of this is currently we're paid based on RUGs, which a RUG is basically a category of the MDS that says how much care a resident's receiving. And that would include things like therapy and IVs, and obviously the more acute a resident is, or the more intense nursing care and therapy that they're getting, the higher the payment. And that's kind of how it's structured right now. It'll be switching over to the patient-driven payment model, and we're still learning about how that will work. But that is actually driven more by the diagnosis of the resident. So if they come in for a left hip, payment is going to be driven based on everything that we're doing in accordance with that diagnosis. So it's kind of a shift in how we're paid, but in the end it sounds like it'll be about the same. It's just a little bit of a different approach. So on average, Medicare pays about $10,000 for each readmission to the hospital, so that's why they're looking at it, because obviously they want to move the mark to make that better. And according to the data that CMS has, 78% of readmissions are completely unavoidable, or completely avoidable. So that costs the healthcare system $3.39 billion. So our goal, obviously, would be to meet that threshold and have a readmission rate under 16%. And so when we look at just our Medicare revenue for the past year, we had about $4 million, 4.32. And if you look at 2% of that payment, like if we didn't meet that goal, it would equate to about $86,000. So over the course of the year, that it adds up. And so when we look at our readmission rate from July last year to April of this year, you can see it kind of ebbs and flows a little bit. And that's kind of to be expected depending on the clientele that you have in your building. You can kind of look at, you see it start to go up in October all the way through December. And that's kind of cold and flu season, so you kind of expect to see that a little bit too. But over the course of the year, we looked at our readmissions by time. And again, this is just information. It's, is there a correlation? I don't know. Most readmissions occurred between 7 a.m. and noon in the morning. Some of them occurred in the afternoon, and then they kind of dipped off into the evening and night. And so these are the readmissions by month. So January through May, and then the day of the week. So it looked like Friday and Sunday were the biggest days that we had readmissions. And these were the diagnoses related to readmission. So the other category is kind of the catch-all, so that's why that one has the most, because it could be obviously not a diagnosis that's listed there, but when you look at the readmissions, it's mainly the chronic illness like CHF, there's pneumonia, respiratory, and UTI. When we go to our ACO meetings at Finley, they talk a lot about respiratory. So we're trying to look at different things to see if we can partner better with like respiratory therapists from the hospital when people come here, especially if they have a respiratory diagnosis. So we're trying to do some things to look at it a little bit differently. And then these were the number of monthly transfers and then the number of SBARs that we completed with those transfers. And we know that there is obviously times where, if somebody's having chest pain, you're not going to sit there and complete an SBAR, and you're going to do everything you can to get them out of the building quicker. But, it makes us kind of think a little bit more about, are we catching things early? Are we missing something on condition changes? Are people passing information along? So again, just informational. And when we looked at the data from CMS for readmissions, that 16% readmission rate or less is obviously the goal that all nursing homes will have, and that will be our goal as well. But in 2017, 96% of the nursing homes would not meet that benchmark. Only 4% would meet the benchmark to have a 16% or less readmission rate. So that's not a good statistic for us, but again, just informational. So that takes us to looking at our processes. One of the things that we want to talk a little bit about today is the Stop and Watch tool. I'm sure some of you have seen those out. We did have a CNA and CMA meeting on September 13th, and we talked with them about using the Stop and Watch tool. We will be talking to other departments about using the Stop and Watch tool, and we'll talk more about that. We also talked a little bit about it in the June meeting, and we had Lori Parsons from Telegen come and speak about that. Using the SBAR, which we've been doing that for a while now, and we kind of wanted to talk a little bit more about that. Contacting the doctor to inform of resident changes, and then looking at a palliative care program. So Jen will kind of revisit the Stop and Watch tool, and then we'll talk a little bit about the SBAR.
So, the stop and watch tool, they've already been distributed to the stations, and then at our June meeting when Lori Parsons came, she reviewed it a little bit. But the purpose of it is basically to detect, condition changes earlier, and, which might prevent a transfer out to the hospital. Anybody can use the stop and watch tool that has resident contact, so it's not just for the CNAs. I mean, dietary can use it, housekeeping, anybody that notices a change in condition. Basically, they'll complete the stop and watch form and then give it to you guys, and then there'll be copies. This is what it looks like here, and there's a carbon copy, so they would just tear off the top sheet and give it to the nurse. These are just some examples of different things, you know, mental status changes, frequency, agitation, just any change in the resident's normal condition. They're just some examples. That's what the tool looks like. Seems different than usual, talks or communicates less, overall needs more help, pain, ate less, no bowel movement in 3 days or diarrhea, drank less, weight change, agitated or nervous, tired, weak, confused, drowsy, change in skin color, and help with walking, transferring, or toileting more than usual. So basically, when you're reviewing it, you can kind of go assess the patient and then determine what the next steps will be from that information.
Has anybody been using those? Just out of
I've
curiosity.
had a couple up on our station.
Have they been helpful?
What are we supposed to do with them when we're?
You can shred them because we do have the carbon copy on the notepad.
Okay.
So if a caregiver or somebody gives you a stop and watch, you assess the resident and either you follow up with the physician and the family, or you look into it and you're like, there's not really any change there. You can just shred the white copy. That's a good question. We didn't really clarify that, and I know a couple nurses asked Jerry about it, so.
Are they supposed to be giving those for everything, like say a bruise or anything like that?
They can. I mean, I've had one on one of my stations for a new area on the toe that the caregiver noticed when they were washing somebody up, so they.
Like just average bruises, like on a leg or an abdomen or something like that. I was telling them they might get bombarded with these things if they start doing that.
I guess it kind of depends. I mean, you can direct how you want to do it. I mean, I
guess
know if the nurse is super busy, I know
It's
the nurse
easy.
that I had
It's a
said just fill it out and
communication
then
channel,
just
so-
give it to me so I can follow up later. You know, instead of interrupting, so.
And I just wanna throw something out there. Bruises on an abdomen when they're getting insulin there, dumb.
Don't disagree.
Yeah, exactly.
Why are we continuing to track bruises?
Continue to track them.
Yeah.
You mean like all bruises, or just
Like
in
I
general?
still fail to understand the reason why.
Why we have to look at them every.
No, why,
Because I think-
why we even track
Because
bruises?
if we feel there's
If
any
only
fault
us,
of
the
abuse,
majority
we
of the
have
nursing
to
homes
report
don't
it.
track them. I mean, I understand if they're a large area,
Yeah,
that would be,
or if it looks suspicious and the
yeah,
person's not
if
gonna,
they're suspicious, that's obviously you're gonna investigate and report that, but.
yeah,
They
we,
come in at an admission when they have 17 bruises,
I know.
and we're looking at them for.
Well, and
Week
Aaron's
upon
gonna be
week upon
looking
week.
at that skin
None of the
policy.
And I'll
hospitals
tell you
track
what,
bruises.
These
Why is it
residents are
theirs
not
and
happy
some
when I'm in
of
there at
them
midnight
don't?
going, okay, I'm gonna lift your gown up now, and I'm gonna roll you this way, I'm gonna roll you that way, I'm gonna measure this bruise.
we'll check,
But they're not.
we will check into that, because if that's, I mean, obviously, we wouldn't wanna create more work when it's not really something that is, necessary,
Warranted,
so.
If they're uncombed in and they got a critical INR or something like that, I understand then we should be watching stuff closely, but, I mean, most people, why we bump their arm on something, we gotta bug them for, get in the wintertime, everybody's gonna start wrapping up in long sleeves and stuff, and then they're gonna start rolling those things up and
Yeah.
take them in.
Yeah.
Well, we talked about, changing the form too, you know, how we have the skin tear laceration form, and then we have the bruise form. Really, if there's like a skin change or a skin issue that's identified, we should be able to just have a simple form that just says, what did you notice, what are the measurements, and I don't know why there's two forms either. So, we will be looking into that because, yeah, I think we could do something different there, something better. Yeah, make it simple.
So there is a pad on every nurse's station, and like I said, once it's completed, they will give it to the nurse, and then, you know, you can follow up and determine if an S-bar needs to be done, or maybe therapy orders needed, or whatever needs to be done upon your assessment.
So we had our quarterly QA meeting last Thursday, and we met with the medical directors and we talked about the readmissions and we talked about, you know, how can we partner better with the physician groups and try to figure things out, because a lot of times, I know you're calling and you're saying, we have these changes, and you might be getting an on-call, and the on-call is saying, well, I don't really know this person, so send them to the ER, you know, so it's not just us looking at it, it's obviously looking at the system and how we can partner better with people that we work with, but we looked at the SBAR tool that we have, the one out of Matrix, the 3.0, and that's an interact tool, and you know, they built the form, they designed the form, we're just using it. But the medical directors kind of talked about, you know, they would prefer it to be maybe less than what's on there, because it's pretty lengthy, and sometimes it goes into, you know, looking at the GI system, and you might be calling because they have chest, I don't know,
A cough.
a cough, yeah. And so, you know, why are you looking at all these other things when you've obviously identified what the change has been? So I kind of wanted to see from you guys, do you feel like there's too much on there? Are there things on there that we should maybe look to take off and build our own?
Couldn't there just be a box that said not applicable?
Could be.
You know what
I
I'm
mean,
saying?
Or just a box where you fill in what the issue is versus every organ system?
Right, and that's kind of what they talked about too, just saying, okay, well, this is what the problem is, this is my
Recommendation.
background as far as have they had any med changes, just any high level things, and then this is my assessment, and this is what I am requesting or recommending.
Yeah.
So it's short and sweet and to the
One
point.
page.
Do we think that we'd like that better maybe?
Yes.
Yeah.
So I can put something together and we'll look at it, and then I'll send it out to you guys, and then if you have feedback, we can go from there. Because there is an SBAR 4.0 tool, and we're using the 3.0. We looked at the 4.0 and it's like 3 pages longer. And there's so much more to it, so we're like, I don't know. That's why we talked to them about it, to see what they liked or what they preferred as physicians. And then, yeah, that's kind of what they told us. Kind of
Yeah,
scale
it's
it.
too bad that you could
Scale
just
it
go to
back.
the system that you wanna look at.
I think
You know,
it's important.
Just to make sure you have all your ducks in a row for that particular system when you're asking for something.
Yep,
I think it's important too to make sure to let them know what we can do here. 'Cause
yeah.
A lot of times they don't know that.
Yep, I would agree. And on the bottom of the form, you know, there's different things, like I'm requesting lab work, or I'm requesting an appointment, but it might not mean that I have to send them to the ER. So, just some things to think about. So then, the next thing that we wanted to talk about is the UTIS bar, because we do have standing orders to check urine, and then if it's positive, to send it over to the lab for culture and get orders from there. So Rachel's gonna talk a little bit about that.
So the medical directors recently signed a standing order that when we have UTI symptoms, we can automatically collect the UA and run the Clinitech here, send it over to lab if it's positive, and we don't have to call the doctor. We can skip that first step of calling and saying, can we get a UA order? So basically, there's criteria, so we're gonna have a UTI S-bar. It's gonna be separate than the other S-bar. There's 2 of them, one for catheter, one for anybody that doesn't have a catheter. So you'll go through the S-bar, and there's different criteria that it lists right there. You'll see if they meet any of those criteria. You can go ahead and collect the urine, run it on the Clinitech, and then if it's positive on the Clinitech, send it to the lab. The one thing we're changing, we were sending to the lab only for a CNS if it was positive. We're gonna run the full UA and CNS, and that was by physician request. They don't like that we don't have the full UA, so they wanna know what the WBCs are, and we don't have that on the Clinitech. So that's one thing we're changing there.
So we're always sending it?
Only if it's positive.
Oh.
If it's positive, then we send it and do the full UA and CNS, rather than just the CNS.
Oh, gotcha.
I'm not
They-
sure how much leeway you have, but, you know, in the hospitals, that's how you got around a lot of sending them to the hospital. We're gonna say it was a nursing home.
Yeah.
But they have a lot of standing orders,
Mhm.
you know, and that's where I think you guys need to start, cause that Clinitech has saved probably how many calls to the physicians. And I think if we had a little more, like I said, leeway, I don't know how much you guys can have with the state and everything, because they're a lot fussier than the hospitals, but maybe you guys can start looking into how much rope they can give us, because, you know, I can see so many things that we could probably do without ever calling the physician, you know? And say, and we wouldn't even have to send them to hospitals. I mean, nurses do a lot, obviously, and we are, you know, we're as intelligent as the doctors and sometimes far, and look at how much time we spend with the residents. We know a lot more than they'll ever know. And like you say, we call an on-call physician and they have no idea. They've never seen it. They don't, I mean, we spend, you know, 24 hours, I mean, we spend 5-6 days a week with them. And I just think if we can start looking into, obviously state will have to allow it, you know, and they're fussy, but I just think maybe if you see what they can allow us, I think that would save a lot of hospital trips. Like with the SARS, for a while there with the low blood sugars and everything, you know, I think if, give them some sugar, give them a glucose tablet, you know, I mean, that should just be random, obvious to, I mean, people can take blood tablet, or glucose tablets at home, you know, it's just so obvious to you and me, and I know state just looks at us like we're crazy, but they do it at home, you know? So maybe you can look into stuff like that, you know?
Having more standing
That's
orders.
a great point.
A lot of standing orders, I mean, the hospital has thousands of them, and you guys maybe if you can just start with number one, but just getting some standing orders would save a lot of hospital trips.
And that's what we're trying to do with the UTI part, starting with that, having standing orders that, you know, this is the criteria they have to meet. If they meet that, then we're independent to be able to
Right.
run that UA and get the results and send it to lab.
We also do negate some of that by having the confirmation of orders, like just the Tylenol
Yeah.
and the Milkamag and different things like that, that at least we have those on board even if they don't ever use them.
Right.
It'd be nice if we had like Tums or something too.
Yeah, we need to
Yeah,
talk
tell
about
us.
that before I go.
Yeah, anything that needs to be added,
Aaron,
yeah, we can add.
We can make it 2 pages long.
It should be not a confirmation, but upon admission.
Just a standing
Yes.
order upon
Yes.
We would
admission,
like to
right.
have, yeah.
Yeah,
Cough drops,
yeah.
cough drops. For sure.
so once we get the results of the culture and the urine, we're gonna take the UTIS bar and send over the lab results to the physician at that point. So we're gonna get the culture results before we send it over, so they have all the information to decide what antibiotic to prescribe. And that's gonna avoid us starting this antibiotic and then 2 days later changing it to this one, and so,
So when we get the initial report, we're no longer calling the doctor immediately on them?
no, it should be the culture with the culture, yeah.
2 days.
Yeah. And that is recommended by, with the antibiotic stewardship stuff, to have that culture. Now, if they're having fever and severe symptoms, use your judgment. I mean, if there's something that you don't think we should wait and we need to act on quickly, then okay. But if they're
We
just,
should put guidelines in place then as to what they need to do for reporting, because we're not gonna get
yeah,
that compliance with all the
it's
nurses.
supposed to be, get the culture results, send it to the physician. But if you got somebody that you don't think waiting a couple days is
Showing
gonna,
signs of
yeah,
sepsis or
yeah,
something.
I mean,
I'm
it's,
Yeah.
not saying that one nurse won't
Keep
pick
up
up on
with
within 2 days, this
Yeah.
person's gonna be septic, but some might not. And then, so I think there should be at least some certain guidelines, if they're running a fever that's X amount, or, you know, maybe spell it out, for especially like newer nurses and experience.
There was something
We
in
do a lot
there
of those in here.
for the pilot that we could look at, because it had like temp over this, you know, for the sepsis. We can look at that.
okay.
But then
Good.
again, a lot of elderly
Actually,
don't run
yeah.
temps. Sometimes.
There was other things listed.
Yeah. Because we should be still assessing the resident while we're waiting for these culture results. We should be still doing our assessment, and, because if we're running the UA, then there must be symptoms and there's a reason we're doing it, so
And actually,
there should be an
blood pressure
assessment
would
along the
reflect,
way.
because if you're gonna see septic, you're gonna see a change in blood pressure before you see anything, honestly.
Yeah.
Any other questions about this? Alright. So then we have Katie Sadler from Therapy to kind of introduce herself. She's our new director of therapy. And she's with Aegis, and she wanted to talk a little bit about referring people to therapy, especially if they're long-term care, And, you know, if you're noticing changes with them, she kind of wanted to talk a little bit about that. And that kind of goes along with stop and watch. You know, maybe somebody's just having a decline that the CNAs are noticing, and maybe they're just physically having a change with their abilities. So that's where therapy could help with that.
Hello. So basically what I wanted to kind of go over was different things you can look at for physical therapy, occupational therapy, and speech therapy. You guys do a really good job of referring and getting orders and those kind of things if you notice something. Physical therapy, I guess some of the things they can work on. One of the things we kind of want to really kind of hit hard and pay a lot of attention to is like pain right now. Because you guys, I mean, we get the pain report, or, you know, I get the list for pain on the morning update or whatever, but I think if you guys see something, you know, that you know, they're having lots of pain in their back, or they're having pain in their arms when you're, you know, when you're lifting them or taking a drink or any of that kind of stuff. If you notice those kind of things, we can work on, we can do modalities, we can do different things, range of motion, different set up restorative programs to help with the pain that way. I just want to make sure we're not missing that and just giving them a Tylenol or a pain pill, you know, instead of that. They can work PT, balance, if you notice any balance, more difficulty getting up out of chairs. Transfers walking, if they're taking longer to walk, having a little bit more shuffled gait or any of those kind of things. If you see that maybe we need to switch an adaptive device as far as like a walker or those kind of things, you can refer them to physical therapy. Even if it's just say, you know, for us to take a look at them, it doesn't have to be an actual evaluation. We can do a screen on and say, you know what, they're okay this way, or keep them where they're at. If you have questions about like declines, but also if they're getting better, like if they're on a Hoyer lift and you say, you know what, I think we can make it a 2-person so we don't have to use those, we can refer to PT and OT to check out those things and make recommendations that way. Occupational therapy, bathing, dressing, toileting, hygiene, if you notice that they're having more difficulty wiping themselves or any of those kind of things. Urinary incontinence, we can teach them exercises to help with some of the urinary incontinence issues that they might have, which could be some of the UTIs that we're having too. So if you notice somebody that's getting UTIs a lot, you could always refer them to OT and we can work on some of those things. Feeding, just even if you notice them at the table and they're having trouble, they're covered in food or that they're having, you know, the food's all around the table or anything like that, we can look at different equipment that they might need or that they could have to help with that. And upper body is kind of pain. For OT is upper body, PT is usually lower body. So, but if you have any questions, just you can always refer to OT and PT or call me or whatever.
Do you still evaluate if they're hospice?
We can if hospice asks or agrees to it. But, yep, no, if they're hospice, we can't. Sometimes they give us, if it's like a wheelchair thing, they might say OT in there for wheelchair assessment, positioning for 3 visits. But typically, we can't evaluate anybody, or we don't usually pick them up under hospice, or, you know, unless they ask us to. And speech, voice, Andrew and Becky's a new speech therapist. They both can work on voice. So if you notice that you're having any trouble hearing them a little bit more and they're not able to vocalize, you can refer them to speech therapy. Swallowing. They also do a lot of cognition. So if you notice a decline in the cognition or memory or ability to follow directions, those kind of things, you can refer them to speech. But like I said, if you have any questions about who, just call me up and I can let you know who would be appropriate that way. I was getting the orders, but now I don't know if you guys have, I know that I've called up and had you guys get orders, but nursing is going to be getting all the Part B orders for therapy, which you have for like the last month. I mean, usually if I have a, referral, I'll call up and say, can you get orders or whatever. But, so because you guys, the doctors for some reason respond to you guys a lot quicker than they were me. I wasn't getting orders back for like 3-4 days, so. So just what you can do, if you get an order, send me an email. It's at Catherine.Sather@Aegis Therapies. It's on your guys' thing. You can send an email. And then I usually go ahead and get the insurance verification, and then we'll start them on therapy as soon as we can. Sometimes it takes a little bit of time to get all the ducks in a row, but we'll pick them up as quick as we can. And like Matt said, we're with that new stop and watch tool. We're hoping that we can get catch some of these people that are having a little decline, and you're not noticing. This may help people notice a little quicker, and we can get some people started on some therapy. And also we went and looked at everybody in the building for the bed rails, who has bed rails, who doesn't. So that's what we're gonna do is everybody that does, part of the policy was to have OT assess them. So I have it's a big list. So I'm gonna start going down that list and calling up and saying, hey, I need orders for occupational therapy to assess for bed mobility and side rail assessment. And so it'll be just therapy going in and doing like a one-time eval, just saying, yes, they need the bed rails, no, they do not. And then if they need them, then we have to get the family to have to sign the waiver. But so you'll be probably getting quite a few more orders for us that way, because I have pretty much the whole, most of the building that we have to do this on. So, but like I said, it'll be a one-time assessment, evaluate them, and then make recommendations, and then we'll update the care plan after that. Any questions about anything for therapy?
To touch on the bed rail piece too, the care plan nurses will be responsible for getting the consents if they are gonna keep the bed rails, so that's not anything that you guys would have to do, but you will be getting requests from Katie to get orders to assess the
Could we
rest
start
of it.
getting the orders?
Yeah, I have a list. I think we're gonna start. Cheryl had asked if we would maybe start up on third floor, so I think that's where I'm gonna start and kind of go down. Unless there's something you want to know right away, call me up and say, hey, Katie, can we do this one now? If you have concerns, or if you know that somebody that wants them really bad, or needs them, then just call and you can get the order right away. So, but anytime, if you have any concerns and see a big change, just go ahead and get the order, and then just call down, and it just saves a lot of time. If just say, hey, Katie got orders for this person, weakness, whatever, change, and then we'll get it just kind of quicker if you do that rather than having a screen anyways, so. But, anything else?
Something real quick. Just a reminder to call you when we get speech therapy orders. Like a lot of times when the confirmation comes back, it has speech orders on it, and therapy doesn't always know right away, so just a reminder. We're
Yeah.
working on getting those upon admission too.
Yeah, usually anybody that comes in, everybody's really good about telling me about OTPT, but they forget about on the clarification or speech to tell me that, hey, there is speech. Another thing on that form, Jen, is I think some of them circle it and some of them just leave it blank. I don't know if we can, how do you want them to do that for that
Usually,
confirmation?
I typically just say just leave it blank, because then we have all three.
Okay. Yeah, because I don't know, because sometimes when they come back and I'm looking in there, sometimes people have them circled, so then I'm like, okay, they do, and then sometimes people leave them blank, so I'm like, do they have them, do they not, do they want them? And some people cross them out, so I didn't know what,
Yeah, if they're crossed out, then we wouldn't have.
Right,
the order.
but I
So
mean-
that's why I usually say just leave it blank.
leave it, don't do anything, okay. That way I know that if it's nothing's changed on it, that
I
it'll
mean,
be speeches included.
Circle it, doesn't really matter, but. As long as it's not crossed out.
Anything else? But I am down on ground. 1119 is the extension if you ever need to call or anything, but we're on the list, so But like I said, anytime, email, or, email me, call down. If you have any questions about anything, just about any patients or anything, you can, call. I can come up and run up and see the patient or whatever you need, so. I'm here to help if you need anything.
Perfect. Thank you very,
Thank you.
very much. All right, so then the next piece we wanted to talk about was communication and the huddle boards and shift change handoff, so.
Good morning, everybody. Okay. So huddle boards, and I don't know if any of you are in my group. Sammy was there. We had a group, a meeting, and we're gonna have another one, a couple more until we get this all figured out. But we're working on the best way to communicate throughout the building, as far as what is pertinent and what is really not pertinent, what's on the huddle boards, what's on our CNA sheets. The CNAs really like those sheets. They like to have something in their pocket and write their own notes on them, which I'm fine with that. But the consistent piece that we want throughout the entire building is the huddle boards. So right now, we're looking at them to see if we wanna revamp them. Because some of those categories, like in skilled, obviously they use the admissions and discharges a heck of a lot more than long-term care is going to, because sometimes we hardly ever get admissions, But items on there that you think we may not necessarily need, you don't ever use, or something that's not on there that you would like to see that you would think would help improve communication. Thoughts, ideas. Another thing that we kind of talked about in the meeting was to kind of separate the two, because currently it's mostly, some of the feedback I've gotten from the CNAs is that it's mostly like a nursing thing, but we want the CNAs to go there to utilize it, to get the information that they need. If the nurse happens to be busy and they can't, they can go there and say, if they wonder, is 306, is she skilled? She came back from the hospital, is she skilled or is she not skilled? They can go there and look and get their answer without having to necessarily come hunt you down in a room or something like that. So we talked about having one side or section be just CNA and one side be for the nurses, so that they have what they need that's pertinent to them, and then other things that they don't need can be on the nurse side. Anybody have anything they want on there that's not on there currently? I guess I'll sleep it.
I don't think people are using them appropriately.
I was gonna say, I don't think we are either, we don't know directly know what, and also, does everybody have the boards that we have?
They're all the exact same right now.
But I mean the board
But
that
the
we write
same.
on, that you guys pick up?
Oh, the 24-hour report?
Yeah, cause that is more usable, and I always tell my aides to look on that if they wanna know the discharges, appointments, all that kinda stuff, cause I do forget to write on those things one time, and the dates, like she said, we don't use them as much, but I said, well, go look on the 24-hour board, cause you're gonna find more information on that than you are on the.
Well, to be honest, the 24-hour report sheet might go away.
Okay, well then we will write on the thing more, but that
Exactly.
needs to be.
And that's part of the problem,
But half the
is
stuff
that right
that-
now, people have worksheets, people have huddle board, people have the 24-hour
Right.
sheet, people tell each other stuff and then it gets forgotten later. We need to narrow it down and keep it consistent so that it gets through. Because otherwise, how many times do you hear, well, I haven't been here for 2 or 3 days, but so-and-so didn't tell me that, I didn't know that, well, maybe they've been here for the last 3 days and knew it happened 2 days ago, and to them, that way, if we have it on the huddle board and it's been there and you go and look at it, oh, Sally had a fall 2 days ago.
Then, like you said,
It might not pop up, it might be done, the follow-up, or 3 days ago, it might be done by now, but at least you're aware that she had a recent fall. You're gonna kinda keep an extra eye on her, if bruises pop up, stuff like that.
Then you need one thing, like you said, because if you have 3 different things, this floor's gonna write in that, this floor's gonna write in
Right.
that floor's gonna write in that.
Right. And basically, what I think is gonna happen probably is a huddle board, and then the cheat sheet, so to speak, that the CNAs use, because they do really like that and like having it in their pockets.
Is that like a report board, a
Yeah.
report sheet?
Yeah.
Yeah, okay.
Yep, which I'm fine with. But okay, so this morning I was up on third floor household when they did their report. Their nurse comes and tells their CNAs, like, these are my people on my BM list, These are my people that I have appointments for. These are my people, you know, that I need at this place at this time, things like that. That's what the huddles are supposed to be about, basically. But if we don't have time to get that little bit of a huddle in, we want that all on the huddle board so that they know exactly what their plan is for the day. That make sense? We really need to start utilizing those boards so that we do have a consistent place. And that's basically what my little committee is for, is to narrow down and to see what we think are the best ways to do that. So any input you have at all, I would appreciate. If after this meeting you think of something that you, oh gosh, I really wish that we had, you know, whatever on there, just let me know. One of the things that my bigger units on Third, I know 3 North has been doing it really well, the bath aid. Now that we only have one bath aid for the whole, all the shifts, she, you know, she has all her Monday people, and if one of them refused today, she's gonna go and she writes it in her section that says, you know, 316 didn't get a bath today because he refused. So then when second shift comes and they look at that, they know, I gotta get 316 in the tub tonight. Stuff like that is what we want it used for, so that it's, people are getting the info they need and things get done. Okay, if you think of anything, let me know, because I'm happy, I want it to be user-friendly for all of you.
Alright, so then the next thing that we kind of wanted to talk a little bit about was the med treatment carts. I did send out some emails and kind of the plans for the carts that we're looking to get for 2 South, 3 South, and 3 North. But basically the concept we want to go with is the concept that we've been using in the households, where the meds and the treatments are in a similar place. I know in the households the meds are in the cabinets as well. And eventually on 2nd floor and 3rd floor, the arrangement will be the same as the households, but they're not yet remodeled. So for the time being, we will be setting up med and treatment carts by hallway. So we will be ordering 6 of these carts, 2 for each station. And out of the 6 carts, 3 of them will have a narcotic box, so there will only be 1 box per unit. But they will look like this. They will be set up very similar to the carts in the households. They're a little bit bigger, just because of the number of med cards and things that are going to be stored there. It's a little different than the households, again, because of the cabinets in the rooms. But we felt like this would be a better model for delivery of meds compared to, you know, kind of the structure that we have right now. Residents are coming up, you know, throughout the day, and we're passing from the desk, which, I mean, is fine if there's, you know, 1 or 2 people there, but they start to line up. And it just looks very institutional, and it's not very dignified. If, you know, I was a resident here and I had to sit there and wait for my meds, and have everybody watch me sit there and wait for my meds, it would, you know, not really be what I would be looking for in the day, I guess. So the other issue was, you know, with the barcode scanners, you know, we're really wanting everybody to be using those. I think people have started using them a lot more than we had in the past, which is great. So if you're using them, thank you. And if you're not using them, please start. I know that there's been some bumps in the road with that process as well, and we're continuing to work through some of those issues as they come up. So if you have an issue, please let me know, because I am letting Matrix Care know when something doesn't go the way that it should. But with moving to these carts, there will be a barcode scanner on each of the carts. So right now, you know, on those floors, they're passing meds a lot of times with the med aid and the nurse. So there's 2 people passing meds out of 1 cart, which, if you think about it, it could be a little bit of a safety issue. It is a safety issue, because I could be grabbing stuff and working from one area, and they could be going in before I have things signed out and grabbing stuff, and there's just more hands in the pot, so to speak, and there's just more potential for an error. So that's kind of what the plan is. I have ordered these carts. They'll be here, I think, in 3 to 4 weeks. And we tried to talk with the people that are working in those floors to look at what's really pertinent, what do they want on the carts. We tried to set them up with everything that we thought that you guys would use, so that they're kind of customized. But, any questions about that change?
Are we by chance like getting new laptops, because like our laptops on 3 North do not hold a charge for more than maybe an hour, it'll die before my passed over.
So they will be putting the tangents on
Oh, they are,
these.
imagine.
Yep,
Okay.
so they're gonna, you can kind of see the little mount in the corner, I kind of cut it off when I cropped the picture, but they will have the tangents.
Okay.
So, the treatment card will go away, and then the med card, the gray ones will go away. And you'll have these with the tangent on top of
Okay.
them. And the goal also would be to move the cart, to use the cart, you know, up and down the hallway. Any other questions about that?
You know, with the old treatment cards.
Good question. So the old treatment carts, we did talk about converting those into the crash carts. Just to have them be a little bit more organized. Do you guys like that idea? Instead of like the PVC pipe push carts? I thought it would look a little bit more official and you
You
would.
have to keep it locked.
No, the treatment card
If we're using it as a crash card then.
You don't have to lock it.
'Cause- well, yeah,
We don't have medications on them.
well, yeah.
We
So,
wouldn't have
'cause
to
I was
keep
just
them
wondering, cause like that
You
would be
wouldn't want
kinda
it
inconvenient.
No.
Yeah,
Okay.
or we could program them with just a simple close. The new carts, these carts, I know you can see like they have the lock like one South has. They will have a keypad, just like you have now, so anyway.
Did you mention the scanners?
About-
They scan.
Yep, yep.
Let me say something about scanning, because I forgot to send an email about this. I had several people last night that were scanning meds, and they were saying that these orders were discontinued, but they were not.
Okay, yeah, we had one of those come up on Monday.
Two
Is
different
it-
people reported it. And like, I verified that the orders were not ever discontinued, and they were still active and whatever.
Will you send me, do you know who they were? and stuff?
Yeah, I'll think about it.
Just let me know.
Yeah, I'll let you know.
And I'll send it to them.
Just tired.
Cause yeah, when those come up, when those do come up, you know, please let me know about them so that we can try to figure out why it's not working. And I'm gonna talk to them about the stock meds too, because I know that's an issue, and the way that the import works is when they enter a medication in the pharmacy side and they have a RX number, that barcode is matched with, you know, what they send us. So on stock meds, like the RX number is not really linked to a specific resident, so I don't know how they'll ever, the way that that's set up, I don't know how they'll ever fix that.
Cause that's what I'd have problems scanning those.
Yeah, the stock, that never works. But my thought would be, I know that it's kind of an interruption in the workflow, so like when you're scanning and then you gotta stop and, you know, take out a stock and then prep it, and it's a different process than what you're doing for scanning, that's probably another reason why people aren't using them. I'm gonna ask Matrix to see if they can sort them. So, like your scan meds, like prescription meds would come up first, and then your stock meds would be on the bottom, so then you can scan your cards and then prep your stock.
So the cards, they scan off of what just seems to be a standard barcode. Can't they just make a generic code for acetaminophen 325 and send us a sheet that we can stick on our stock items that we could scan? That way it would automatically be set up to that number, and then
I can ask. I think what the problem is when they do those RX numbers on the order, it's specific to like who they're billing or whatever, and specific to, they wanna be able to link that med to whoever's gonna be getting it. And so for stock meds, when they put them in, they do still have their own RX number, but if they made them all the same,
But they're not billing for those, because the stock
Right,
meds we
right.
pay for.
we're just trying to get it where they can
yeah,
scan them.
yeah, I would agree. That would, and the insulin's the other problem, because, you know, they're importing sliding scale, and the sliding scale isn't coming up the way, you know, that we set it up in our system. and the way that it's scanning, it doesn't work. But anyway, so we're gonna continue to work with them on that,
Is
but.
the scanner, like, it's supposed to like stay on all the time, right? Like, you don't have to push the button, cause the one on 3 North isn't like staying on all the time.
I was gonna
You
say,
have to
Glenn knows
push the
that,
button
that one
every
does it,
time.
and he said that you have to use.
Glenn's looked at it. Because the
Yeah.
other day it was working, right, you just put it on there and it scans. Cause I know
Yeah.
Glenn's been looking at it, I have to hit the button every time I scan something.
Well, I know he had put a rubber band around it so it would stay on, so if
I don't,
someone
yeah, I don't know
moved
if somebody took it off or what, I wasn't sure.
that was why it was.
I'll
on
ask
that.
him about that scanner.
I know.
Is anybody else having any problems with scanners? But that's 3 North.
Yeah, I understand it's good with that one.
Okay, I'll ask him, because it would be weird that we would have.
Yeah, I mean,
one
the other
in
day there
building
could
that
have been
doesn't
a
work right.
rubber band on it and I just didn't notice that there was one and there wasn't today yet.
Oh.
But
Okay, I'll ask him about that. Then to kind of circle back to our meeting from June, and to circle back to our state survey, call-out response times were an issue during the state survey. We're continuing to look at them, we're auditing them randomly, and then we're also auditing at least weekly, looking at the call-out times. For the most part, they've been much better, so great job. But it'll continue to be a focus, and it'll continue to be something that we all have to pay attention to. And one of the things that we are talking about is a different call-out system. And so we're looking at maybe getting a wireless call-out system so that the residents would wear a pendant for their call-out. We would also be able to track where they're at in the building with that pendant. The other advantage of this would be that we'd be able to link this system to mobile devices, and we'd be able to give CNAs like a cell phone that would be locked down, like they couldn't use internet, they couldn't use anything but the call-out system on the cell phone. So like when a call-out would go off, it would alert their phone, and they could communicate with each other to say, I'm gonna answer this call-out, and it would send a message to them, the other people that they're working with on the floor. They could actually call each other on the phone and say, I'm in with resident 110, kind of like the walkie-talkie concept. They could send text messages through the phone, and it's a secured network, so then they could communicate that way. And then they'd also be able to document on the phone. So then
So
it's
if you had somebody that was sitting outside, they could